Hello everyone. Today we will learn regarding elbow joint. Elbow joint is one of the important topic for exam. Elbow joint type. Elbow joint is a hinge variety of sineval joint between the lower end of the humerus and the upper end of the radius and ulna bones. Elbow joint is the term used for the humeroradial, humero-ulnar joints. The term elbow joint, elbow complex also includes the superior radio-ulnar joint. We have seen the definition of complex joint that there will be articulation of more than two bones. Okay, this term as complex joint. Now we will discuss regarding articular surface. Upper, the capitulum and trochlea of the humerus. Lower, upper surface of the head of the radius articulates with the capitulum. Trochlear notch of the ulna articulates with the trochlea of the humerus. Okay, in this diagram we can see capitulum of the humerus articulates with the upper surface of the head of the radius. Trochlea of the humerus articulates with the trochlear notch of the ulna. Superior radio-ulnar joint. It is formed by the circumference of the head of the radius articulates with the radial notch of the ulna and form the superior radio-ulnar joint. Okay, and together humero-radial, humero-ulnar and superior radio-ulnar joint are together known as cubital articulation. Okay. The elbow joint is continuous with the superior radio-ulnar joint that we have discussed cubital articulation. Now we will discuss regarding ligaments. Capsule ligament. Superiorly it is attached to the lower end of the humerus in such a way that the capitulum, trochlea, radial fossa, coronoid fossa and olecranon fossa are intracapsular. Infero-medially it is attached to the margin of the trochlear notch of the ulna except laterally. Inferolaterally it is attached to the annular ligament of the superior radio-ulnar joint. The synovial membrane lines the capsule and the fossa named above. The anterior and posterior ligament are thickening of the capsule. Diagram shows the capsule of the elbow joint. It covers the lower end of the humerus, capitulum, trochlea, radial fossa, coronoid fossa, olecranon fossa. Infero-medially it is attached to the ulnar notch except laterally. Inferolaterally it is attached to the superior radio-ulnar joint. Okay. Now ulnar collateral ligament. Shape triangular. Apex is attached to the medial epicondyle of the humerus and base to the ulna. The ligament has thick anterior and posterior bands. These are attached below to the coronoid process and olecranon process respectively. Okay, in this diagram we can see the shape of the ulnar ligament. This is triangular in shape. Apex is attached to the medial epicondyle of the humerus, base to the ulna. Okay. Anterior, posterior band. The lower ends are joined to each other by an oblique band which gives attachment to the thinner intermediate fibers of the ligament. In this diagram we can see oblique band of the ulnar collateral ligament. The ligament is crossed by the ulnar nerve and gives origin to the flexor digitorum superficialis. It is closely related to flexor carpi ulnaris and tricep brachii muscle. Fifth one is radial collateral ligament. It is fan-shaped band extending from the lateral condyle of the humerus to the annular ligament. In ulnar collateral we have discussed that it extends from the medial, whereas in lateral radial collateral from lateral epicondyle to the annular ligament. Okay, so it is easy to remember. It gives origin to supinator and extensor carpi radialis brevis muscle. Okay, radial collateral ligament. Radial collateral ligament, it is fan shape, fan, Japanese fan. It is fan shape, lateral epicondyle of humerus to the annular ligament. Okay. Now we will discuss regarding relation of the elbow joint. Anteriorly brachialis, median nerve, brachial artery and tendon of bicep. Posteriorly tricep and anconeus. Medially ulnar nerve, flexor carpi ulnaris and common flexors. Laterally supinator, extensor carpi radialis brevis and other common extensor. This is the diagram of the relation of the elbow joint. Blood supply from anastomosis around the elbow joint. Anastomosis we have discussed in terminology. Okay, you can see brachial artery, profunda brachii, ulnar artery, radial artery, and anastomosis around the elbow joint in this diagram. Now, nerve supply. It is supplied by ulnar nerve, median nerve, radial nerve, musculocutaneous nerve through its branches to the brachialis. Movements. Flexion is produced by brachialis, bicep and brachioradialis. Extension is produced by tricep and anconeus. Diagram shows the action of the elbow joint: flexion, extension, supination, pronation. Now, carrying angle. Okay, the transverse axis of the elbow joint is directed medially and downward. Medially and downward. Because of this, the extended forearm is not straight in line with the arm, but makes an angle about 30 degrees with it. This is known as carrying angle. Okay, we will discuss in this diagram that in extended forearm it is not straight. Okay, A diagram shows the extended forearm. In B diagram there is the axis of the humerus, and at elbow joint there is transverse axis and axis of forearm. In extension of the forearm, it is not straight, that we can see in diagram A, and it forms the little bit angle. It is about 30 degree, which is termed as carrying angle. Okay, it can be asked in viva. Now carrying angle is formed by the following factor. The medial flange of the trochlea is 6 mm deeper than the lateral flange, that we have discussed in osteology. The superior articular surface of the coronoid process of the ulna is placed oblique to the long axis of the bone. The carrying angle disappears in full flexion of the elbow and also during pronation of the forearm. That you have to do by oneself and feel that. Okay, the forearm comes into line with the arm in the mid prone position, and this is the position in which the hand is mostly used. This arrangement of the gradually increasing carrying angle during extension of the elbow increases the precision with which the hand can be controlled. Okay, now applied aspect. Distension of the elbow joint by an effusion occurs posteriorly because here the capsule is weak and the covering deep fascia is thin. Aspiration is done posteriorly on any side of the olecranon. Dislocation of the elbow joint is usually posterior and is often associated with fracture of the coronoid process, because coronoid process. Okay, the triangular relationship between the olecranon and two humeral epicondyli is lost. Okay, due to dislocation of the elbow joint. Now, subluxation of the head of the radius. Pull elbow occurs in children when the forearm is suddenly pulled in pronation. The head of the radius slips out from the annular ligament that we will see in this diagram. Okay, radial head dislocation from the annular ligament. Okay, so while handling the babies and children, we have to take precautions. Tennis elbow. Abrupt pronation may lead to pain and tenderness over the lateral epicondyle. This is possible due to sprain of radial collateral ligament, tearing of the fibers of the extensor carpi radialis brevis. Tennis elbow. In this diagram, we can see the player action, abrupt pronation repeatedly. In repeated action, cause the tearing of the RCL radial collateral ligament and tearing of the flexor carpi radialis brevis muscles. Okay. Minor's or student elbow is characterized by the effusion into bursa over the subcutaneous posterior surface of the olecranon process that we have discussed in the osteology class of the ulna. Again, this diagram shows the bursitis. Optimum position of the elbow. If only elbow is to be fixed, it is fixed at right angle. If both elbow need to fixation, the right elbow is fixed in a position of the flexion at an angle slightly less than 90 degrees and the left elbow at an angle slightly more than 90 degree. Means elbow is flexed in the position of the flexion at an angle slightly less than 90 degrees and left elbow at angle slightly more than right less than 90 and left more than 90 degrees. In this position, the right hand can be brought to the mouth and left hand can be used cutting up the food. It can also reach to the trouser of the trouser pocket. Okay, in short, right hand less than 90 degree and left elbow more than 90 degree. Okay, golfer elbow. In tennis elbow, we have seen the lateral epicondyle, where in golfer elbow, we will discuss it is a micro trauma of the medial epicondyle of the humerus, occurs commonly in golf players. The common flexor origin undergoes repetitive strain and results in painful condition on the medial side of the elbow. In tennis elbow, we have seen lateral side. Okay, here we have discussed medial side. Okay, applied aspect can be asked in viva. Okay, golfer's elbow, medial epicondyle, tear in the tendon. Okay, thank you everyone.